that I just showed earlier, where you can see the vitreous traction. So here's the same patient after pneumatic retinopexy. The subretinal fluid is present still, but resolving. Obviously, there's posterior fluid, but the area that was treated up in red and blue, you can see the torn area is now flat and the patient's improving slowly. What about peripheral pathologies like vascular lesions? Here we can see a VHL lesion, and we published a few years ago. One of the beauties of having multimodality device, which does FA and ICG simultaneously, is you can get an OCT over the FA and ICG of the lesion in question to really co-localize everything in real time. And again, as we expand this, we're able to move into the era of OCTA also. Here's an example of a capillary hemangioma, which is relatively far out here in the far periphery, almost at the level of the aura, and we can see the detail quite well. And as I mentioned earlier, OCT angiography is expanding its field of view also. We now have the ability to do 24 by 24 millimeter line scans, and with the newer devices, we're able to go out as far as the mid periphery on average to get good OCTA. The far periphery still remains a challenge at this time. What about in vasculitis or uveitis? I know a lot of that is seen all around the world, particularly in the Asian countries here. And multimodality imaging has allowed us to look at uveitis in a very unique way and make pathological correlations. And we can see here that we're able to OCT out all the way out to the far periphery and look at these vascular changes that are happening at the level of the blood vessels. The surgical applications, of course, they continue differentiating retinal schises from retinal detachments. A lot of the pseudo-color imaging has created some artifact and always raised the question of, am I looking at something that's pathologic or is it normal? Now being able to drag and drop a line scan out there and being able to see a schisis or a detachment or peripheral cystoid degeneration or a normal retina helps to differentiate all that. Choroidal pathology also is valuable. We see a lot of tumors and suspicious lesions in the periphery. We're able to get out to the mid and the far periphery. This is an example of a helicoid choroidal lesion, which we can see here. We published a few years ago. This is swept source image, again, a montage, but we can definitely see this choroidal lesion very clearly, and it's out in the mid periphery. We have, of course, those of us that are treating tumors, as Rishi mentioned earlier, we can see these lesions actually are nice to image, and we can actually get volume information as well as height information, potentially even obviating the need for B scans as we get better with this technology. The macula is not without sacrifice here. You know, myopic foveoschisis and Carl and another video was showed earlier. These are very challenging cases. Being able to preoperatively identify and look at the vitreous in its entirety, which is really what's critical in this case. Looking at the degree of schisis that's present just outside the macula as we edge out to the periphery is important, hopefully in the attempt of avoiding any intraoperative breaks. And I think here we can see that very clearly that this retina is very schitic as you go further out from the macula. Macular holes, similarly, I was amazed to see this particular image where in the era when we were looking at enzymatic vitreolysis and we were trying to find these cases with vitreous traction at the flap of the hole. We can see here the flap traction is located all the way out at the level of the equator, and this hole was kept open by that vitreous traction. So really, in summary, I think one of the beauties of ultra wide field and peripheral OCT is that it's expanded our analysis of the periphery. It does help in surgical decision making, particularly as we expand the idea of swept source OCT in procedures like pneumatic retinopexy, and combining ultra wide field imaging with peripheral OCT gives us a more comprehensive approach to management. And I think for the primary eye care setting, as this type of technology becomes readily available for them, being able to correctly detect and identify lesions and properly triage referrals will make a difference in all of our practices. Thank you.
Wonderful talk. Thank you. Time-wise, Chitra, how are we doing, Dr. Chitra?
We're doing okay. We have about 3 talks left. I think we're fine. We can ask a couple of questions if anybody has. I have one.
Go ahead.
Dr. Chowdhury, how do you manage to image, non-cooperative patients, particularly if you do have some pediatric patients? I think it would be a wonderful tool. Look at the retinal periphery in younger kids, especially those with a lot of anomalies and stuff like that. ROP, for example, also, if you would like to see. Have you tried it in any of the younger?
Yeah,
patients?
so obviously we all have uncooperative patients or more challenging patients. One of the ways we can do that is by limiting the averaging that's done by the device. So each machine allows you to increase or decrease the averaging of each B scan. So if you want to get a quick little line scan out to a particular location, one way to do that is just to decrease the averaging. And so that's the approach that we've taken. Some of the devices have eye tracking, so they won't capture the image unless the eye is locked onto. So there's a benefit there. And then occasionally the other eye usually sees well versus the pathologic eye. And as such, we use the external fixation light to help navigate the patient out to where we want.
Can you talk about some of the issues? You know, when Optos and the cameras came out, there was first a little bit of a warping issue, right? Because we're trying to measure certain spots with the camera. And then now with the wide field OCT, is there any sort of warping? Are we seeing the exact magnification or sizing of the pathology the same way in these new devices, or is there some other correction that has to occur in that?
Yeah, so there's no correction now presently for the ultra wide field images localized OCT. It is a one-to-one approach. What we are sort of exploring and having challenges with, and as we expand that technology, is getting better vitreous imaging. So, you know, as we know, as we go further out, the retina gets thinner, but being able to get better vitreous imaging is actually being worked on. And their current model now has increased the power of the laser that's being used for capture, and we are going to be seeing that.
Great. Very good.
Great.
Let's carry on with our next talk. Thanks a lot, Dr. Chaudhary. Very interesting, I must say. So I'd like to introduce next Dr. S. Natarajan. He's been my teacher, so again, a great privilege. He's globally acclaimed for his expertise in VR surgery and ocular trauma and honored by the Government of India with the Padma Shri, one of the highest civilian awards. With 2 generations of ophthalmologists before him, he became a vitreoretinal surgeon at a very early age under the guidance of Padma Bhushan Dr. S.S. Badrinath. He shares a platform with his mentor as a charter inductee in the Retinal Hall of Fame. He has held various posts in the ICO, the AIOS, APOTS, and Global Eye Genetics Consortium, and the list goes on. He's made significant contributions to the academic world with over 200 peer-reviewed publications besides several books and book chapters. He's a recipient of several national and international awards for his exemplary work, including the Senior Achievement Award from AAO and the Achievement Award from APAO as well. He has most recently taken up the challenge of eradicating blindness due to diabetes through a nationwide diabetic retinopathy screening program, which will be spanned over the next 5 years and which will be implemented through the AIOS. I invite you, sir, to give a talk on 3D surgery for diabetic TRDs.
Thank you so much, Chaitra. Always a pleasure. Platform, everybody knows me, as you said. Thank you. Thanks to be with Carl and Rishi. I got a surprise call in the morning. I was thinking I'll meet him here. So this is my new talk. And I always remembered when Dr. Jovanovich said, I don't like new topics, but I'm opposite to him, even though he's my mentor. So, so the 3D fantasy surgery, vitrectomy for proliferative diabetic retinopathy. I don't have any financial interest. We have a big burden of diabetes, and I see Dr. Kim is going to talk on this. The main thing is 77.7 million diabetics are in India. It's an epidemic happening, and I'm going to address traction retinal detachment. And all this is a problem we face, and I think all vitreoretinal surgeons face. So I just want to say that we all know this, and in spite of the laser, the anti-VEGF, and everything, we still have a role to play as a vitreoretinal surgeon. And this is a case 1, 48-year-old male with a sudden diminution of vision in both eyes. He's a diabetic since 11 years, on insulin, on poor glycemic control. His vision in both eyes is counting finger ½ meter. On examination, he had vitreous hemorrhage with diabetic traction retinal detachment in both eyes. And we did vitrectomy in both the eyes, one eye following the other. And this is a 23-gauge vitrectomy. You can see and thanks again to Mark Hawaiian, who came to India in 2004, and we introduced the micro-incision vitreous surgery together. At that time, it was a Boston alarm 25 gauge, and later Class A cut, and Massive did it in 23 gauge, and then now Yusuke introduced 27, and I use all of them. And you see here the aim is to clear the vitreous hemorrhage and post-retraction, tangential traction, and you can see fibrovascular proliferation happening from the disc to the periphery and releasing the tangential traction. And you'll see, in spite of the diathermy and everything, still after cutting, there can be ooze. And now I'm doing the diathermy, and then after diathermy, doing the vitreous cutter, but still it oozes. So I think the best is to arrest the bleeding, and I don't like to increase the intraocular pressure more often. The reason is many times we will end up seeing a pale optic disc after doing a vitrectomy, and already diabetic retinopathy affects the circulation, and then it produces the optic disc pallor. And I think we have to make sure that a raising intraocular pressure should not be the main aim to arrest bleeding. We can do the diathermy, as you see here, the bipolar diathermy, and make sure you remove every action. The idea is again aim at no iatrogenic breaks during the surgery. Here we are clearing and making sure there is no vitreous attached, and following which we do the panretinal photocoagulation. And here I'm using the retinal brush to clear the vitreous hemorrhage in the periphery. And after that you do a panretinal photocoagulation except the optic disc and macula. And I also sometimes use the vitreous cutter itself to do the fluid exchange. And I use a non-expansive SF6 mixture just to leave the eye, the gas for a little longer than a week, so that recurrent bleeding does not happen. Earlier, I used to face a fresh post-operative vitreous hemorrhage, and we used to do vitreous lavage and another procedure, OPD, fluid exchange, by using a 30 gauge and a 10 cc syringe. But I think after using anti-VEGF preoperatively and at the end of the surgery, many times we don't see this. This is a case 2 traction retinal detachment. You can see the preoperative photograph with the fibrovascular proliferation happening, and then you do a 23 gauge vitrectomy. Again, you see remove the vitreous hemorrhage and also clear the anteroposterior traction. And I use here a proportional mode to inject the fluid using the proportional mode cutter. I use the constellation, no financial interest. And you can see once I make a cleavage between the fibrovascular proliferation and the retina, I now using the cutter, and again go into the convex side of the fibrovascular proliferation and cut the membrane, and then again go between the membrane and the see now at present using the proportional mode to push fluid between the membrane and the retina. It's a patient job because you're using unimanual, and I'll be showing you a bimanual also, but you can also use a cutter and do most of the things in traction retinal detachment, but you need a patience, perseverance and persistence, and that's what is important for a diabetic traction retinal detachment. And again, you have to assess the strength of the adhesion as well as the strength of the membrane and the weak retina beneath, because that's where when you pull, there's a risk of using the forceps, there's a risk of traction. And I think that's why Carl is introducing the suction in the membrane peeling. So a similar thing is used possible here. Make a proportional mode, separate the membrane, and then again use the cutter and the suction so that you can trim from the convex side of the fibrovascular proliferation, so that you're not going towards. You can see the blood is being pushed out. It is like they suck and spit. So this is what we do with a backflush needle, and now with the this is just a brush, and you clear the surface of the hemorrhage. Sometimes if you don't clear immediately, there can be a lot of hemorrhage sticking to the retina, so then that can be a problem even in removing. And here the view is a little hazy because the surgery was prolonged, and under air completed the panretinal photocoagulation, and the patient got 6/9 vision. You can see the optic disc is pale, and maybe because of the prolonged surgery or because of the long-standing diabetic with a traction retinal detachment, but the patient was 6/9. This is a case 3, 49-year-old female with a history of diabetes. We were done I don't do the cataract, even though I probably did last cataract in 1984. And I think after that I've never done. And I'm happy we have a team. This is Dr. Kavita Rao, my director of the cataract and cornea services. She does the phaco and phacoemulsification with a foldable intraocular lens. And earlier she was not putting the one suture, but now I think she puts one suture, and I tell them, you do your job and get out, and I'll come in. And after that, I don't have to call them. So this is the, she's doing the phaco part, and then introducing the foldable intraocular lens. And you can see there's no glow. So my surgeons are trained to the cataract, and I actually tell them put the lens and go. I'll be able to see through the binocular indirect ophthalmoscope or the Zeiss one where you can see the wide angle observation system. And now you can see one switcher there, and then proceeding with the 23 gauge vitrectomy, and then so you can see there's a fibrovascular proliferation, which is hemorrhage. So use the vitrectomy to remove the, again, the anteroposterior retraction, and also remove the, and you can see the fibrous tissue while having a traction combined rhegmatogenous retinal detachment. You can see a break, which I have done diathermy of the fibrous tissue as well as the diathermy where the connection was there. And to avoid bleeding, you can see that I'm now using the cutter to clear the fibrous tissue from the disc and the retina. And now I'm using the cutter again to remove the traction, and then I'll do a endodrainage through the break, and then I use a perfluorocarbon liquid to stabilize up to the posterior edge of the break, and then do the fluid air exchange. So here the idea is so that all traction is released, and now I'm under the PFCL using the forceps to remove the fibrovascular adhesion. The idea is again to prevent iatrogenic break close to the optic disc, because it's a dense fibrous tissue with a dense adherence to the underlying retina. And already the combined detachment, there was a rhegmatogenous break was there, so I didn't want to expand more. So here I'm negotiating with the fibrous tissue so that the entire fibrous tissue is removed, and you can see the fibrous tissue is removed, and I'm doing the fluid air exchange endodrainage through the retinal brush, and then you can see the air getting from the anterior to the posterior, and then you will see the retina attached, and then I do a endolaser photocoagulation around that break, and then use a fluid air exchange, and then air gas exchange following that. So, and if you release all the traction, you don't have to use the silicone oil. And I want everybody to know the chapter written by Dr. Jovanovich, the use and abuse of silicone oil. And I think many times people think that you inject oil and you can solve the issues, but actually you can increase the problem. You can see the retina is flat, the optic disc region is fine, and you're now doing the laser around it. And you're doing endolaser around the retinal break, and the retina is totally reattached. And then the eye is replaced with the gas. So here, this is a old video I did archiving, and I'm using the twin light, which is a twin light introducer by Klaus Eckhart, that time made by Dot. And you make an incision, and this has an excellent endo illumination, that is a chandelier illumination. And because of this twin light, it is stable, doesn't move, and usually you will not see much shadow you will be seeing here. And the only thing is to introduce this twin light so that the stiletto, what you are using, you have to use that. But if you put things wrongly, you will not be able to see. So this is a curved with your scissors designed by Jovanovich, where you are using the forceps and using the curved scissors to find the adhesion between the fibrous tissue. You saw using the cutter, I did that. And the previous one, using the cutter, I did the proportional mode. And this is the old method where you use a forceps and you use a curved scissors to release the traction. And this is what, the whole idea is to be meticulous, patient, and perseverant to prevent iatrogenic breaks. And I think I aim at zero iatrogenic break. Still, sometimes it happens. And I think in 95, I think Tijuan published 20% iatrogenic breaks. And I think Jovanovich said, how can you have 20% the iatrogenic break? And I think he said, if you are careless, you will have iatrogenic break. So I think that is stuck in my mind, and I make sure I do meticulously and make sure that you don't produce any iatrogenic break. And you see the meticulous dissection, and you can remove the entire fibrous tissue, and you also make sure you clear the pre-retinal hemorrhage, which is happening following the cutting the fibrous tissue, and you can see almost the entire fibrous tissue is getting removed, and entire traction is released and no break. And this is another patient with a second surgery. You can see a very bad traction retinal attachment with a lot of sclerosed vessel. But again, you can use the forceps and then dissect the membrane. You will be seeing that again no atherogenic happening, and you remove, you can segment, delaminate, and then continue to do that, and finally remove every membrane possible so that you have been clearing the whole eye, and that's how you can continue the. And then, so there are favorable preoperative prognostic factors and favorable preoperative vision factors, and unfavorable is macular detachment, and combined. In India, we see most of them, and whenever I used to operate in Mexico also, I used to see that. So the 3D vitreoretinal surgery is what I enjoy now, revolutionary technology, again, no financial interest. The main thing is I sit back and operate, which I never thought I can do. I sit back like that, and I do the surgery, and I have designed a Maharaja chair. So the idea is to make sure the benefit of using the 3D so that you don't go back like that in front. But I always say you should do a good exercise. It's not just for the position and for your back. And I think all of us know the difference. And yesterday I was talking to Carl that we can't justify the cost and that cost to the patient. And apart from that, it's a beautiful technology. You can see here. So Dr. Kim is going to talk this. This is my All India Ophthalmic Society. So even though I have an aggressive vitreoretinal surgeon managing traction,
we need you to wrap up if you could.
Yeah.
Thank you. Yeah.
Thank you. Yeah. Thank you.
Very nice. So we'll get to questions. I think in the essence of time, we'll go on to Dr. Kim's talk. Dr. Chitra, do you want to introduce Dr. Kim?
Yes, so pleasure to introduce Dr. Kim. He is working as a senior consultant of VR Services, Arvind Eye Hospital and Postgraduate Institute. He has undergone his fellowship training in the specialty both in India and later in the US. Now he's currently the Chief Medical Officer of Arvind Eye Hospital, Madurai, and he has a keen interest in surgical retina with a special interest in telemedicine. He's one of the early pioneers to introduce teleophthalmology in India, and the network through its vision center sees more than 2,000 patients every day. His current interest is in using AI for screening diabetic patients with the presence of DR. Working with Google, he has deployed an AI-based screening tool for real-time use in screening in India itself. Mr. Sundar Pichai of Google has honored him by nominating his work as one of the best to happen in the next 25 years in the Wired magazine. Over to you, sir, and I'm sure you'll be able to give us great insights into the diabetic retinopathy screening in the current era.
Thank you, Chitra. It was my interest that I chose this topic on screening for diabetic retinopathy. I'm sure all of us are aware of the problem of diabetes. It didn't go away anywhere in this COVID era. We continue to have the problems of diabetes and the diabetic retinopathy complications. We have very little data on diabetic retinopathy, most of them from South India, and they range anywhere from 12% to 20% if you compare the rural and the urban areas. So there is a huge problem of diabetes-related complications in the eye, that is the diabetic retinopathy. So what should be done? Obviously, screening for diabetic retinopathy is the important thing that all of us have to do, especially in a country like India, where we have very little access to care for diabetic retinopathy for these patients. So we need to screen these patients. Clinic-based, of course, is very effective. We've been continuing to do outreach screening programs focused on diabetic retinopathy, and of course, telemedicine has played a major role in screening this diabetic retinopathy. Using tele-screening technology helps in screening for diabetic patients because fortunately, diagnosis of diabetic retinopathy is image-based, and anybody looking at the image can make this diagnosis. So patients fund us, and just for completion, I'm just showing the process of tele-screening, where the fundus images are taken from a remote site, sent to a retina specialist, graded, and the report is sent back. We've been doing this for the last 2 decades. in few of the diabetic clinics where the patients, their technician takes the photo, sends it to us, we create a report after a retina specialist grades these images and sends it back. We developed our own software, which is a semi-automated software for doing this purpose. But what has changed in the last decade in this? Because there's been a lot of focus. People have been talking about diabetes and its importance. The prevalence of diabetes has markedly increased from 26 million in 1990s to 65 million in 2016. And if you see the recent data, prevalence of diabetes in the age between 20 to 79 has increased from 61.3 million to 77 million in 2017, in almost 7 to 8 years. And this is graph, or this picture shows clearly in the last 4 decades how the entire scenario changed. This is not just for urban, but it is even in the rural population, you see this huge change. But what has also changed is the availability of better technologies with good communication channels. You have, we started with the V-satellite connectivity, but today the broadband is available almost in every nook and corner of India, so that you can access care even from the remote villages. Large, bulky, expensive cameras are being replaced with small, cheaper, easy to use cameras, which are much more easily portable, makes it easy for us to take it to the remote locations to screen patients anywhere. And of course, with the advent of the AI algorithms in the recent last few years, there's been a vogue. I've been specifically working with the Google, myself and Dr. Rajiv Raman from Shankar Netrali have been working with this team to develop this algorithm, and it's been pretty working well. Just within less than a minute, your image is graded, and the grading levels are thrown up for anybody to see. So this has helped us in our screening. We have started using it in real time in our. So we are now able to. The retina specialists need not spend the time, and also the diabetic clinics are able to get their information within less than a minute, so the patients do not wait to receive these reports. But what has not changed, unfortunately, still there's a lot of low awareness about the diabetic complications in the eye, especially even among the physicians. They talk about everything, nephropathy, neuropathy, but no retinopathy. For some reason, only when a patient loses the vision, they tend to get referred to the ophthalmologist. Even the patients are indifferent. Many of them don't have access to care, and of course, the cost is a prohibitive factor because it also needs a prolonged care. So, who should do this screening? Unfortunately, today it's limited to ophthalmologists, while the target population, that is the diabeticists with the physicians and endocrinologists, and I've been talking talking about the endocrinologists and the primary care physicians taking the onus of screening, and it should not be with the ophthalmologist. Unfortunately, only 1.3% of the general practitioners actually use direct ophthalmoscopes in one of the study because they don't have time, lack of awareness, and of course lack of training. So very few patients are diagnosed early on, and many of them have already lost their vision when they reach to a diabetic clinic. So I just did a few small surveys some time back where it showed that in India, compared to a country like US, where the availability of telescreening or availability of DR care is much better, we still do much less. Only 10% of the ophthalmologists use telemedicine for screening for diabetic retinopathy. So the current model for DR is clinic-based, limited ophthalmologists. We've been doing these outreach and telescreening, as I told you. We've been doing this for the last few years. And we also go to the primary health centers to screen these patients because diabetic patients come to collect their medicine. So this is an opportunistic time when we could have all these pooled diabetics screened for diabetic retinopathy at least once a year. They get their eye screening, and the government ensures, the primary health center doctor ensures that they do get the screening before they get the medicine. There are also some business models that developed one team from the WellCare Health Systems or screening almost 18,000 diabetics in a month, every month by deploying these cameras and using telescreening with remote diagnosis by the ophthalmologist for the diabetic clinics. But what are the challenges to have trained graders? Having retina specialists, time for this is a waste of their time. And of course, there's a time delay in grading and sending it back. But more importantly, there's a lot of inconsistency in grading. With the advent of AI algorithms, there are a lot of algorithms are available, and more importantly, they've been all focusing on diabetic retinopathy because this is one low-hanging fruit that everybody could work on. And then we have quite a few online, offline systems which are really good and can be used in screening for these diabetic patients. We have deployed it in real time in the physician's clinic. We have also advocated using it in anterior segment specialist clinic, where the DR screening can be done much easier and faster. So what are the future? We recently did a study looking at all the studies from Shankar Nethralaya, Arvind, and population-based studies and Mohan diabetic centers, where we looked at the data and we could see the risk factors, that is patients with high risk features, such as people within 50 to 60 years, male, gender, duration. We saw we could almost 93.5% of the patients with PTDR were having these high risk factors. So we showed if you could do some more research on this to identify this high risk target population, and you see focused screening of these patients or people could lead a lot of results in identifying patients who are prone for losing their vision. It's surprising that there are a lot of research going on using AI, and one of this is being published by Google, where they are able to predict the diabetic retinopathy, progression of diabetic retinopathy happening in patients who do not have DR, just by taking their fundus photographs. Of course, this needs a lot of longitudinal data, but it looks like there is a possibility we'll be able to identify diabetic patients early on, even before they develop retinopathy. Of course, there are a lot of biomarkers being identified, but more interestingly, seems to be, just by taking external eye photos, people are able to identify, or it appears there is a possibility you may pick up some of the posterior segment diseases. Of course, this appears very futuristic, but looks like there is a possibility. Of course, with home OCTs and different technology developing, we will find much easier way to reach these diabetic patients early on before they lose their vision. So as I said earlier, the onus of finding the DR cases should be with the diabetologists and physicians, and ophthalmologists should work up with them. And using these technology will play a major role in early identification and preventing the loss of vision. I want to thank the organizers again for this opportunity. Thank you.
Thank you, sir. It was indeed a very, very important topic because of the difficulties we are facing as more and more severe patients are walking into our clinic who have directly coming in with TRDs. We are seeing very, very young patients coming in with TRDs, and it's so difficult to manage, and the quality of their life is affected, very, very early. And some of them seem to be the only earning member of their family. So, Dr. Rishi, is this how severe it is? I mean, and is AI playing a major role in detecting them even in your country? Is it making a difference already?
It's starting to have inroads, Dr. Chitra, but it hasn't hit prime time. Not a lot of people are being screened with AI methods. And I would say COVID-19 has been quite interesting to see patients come back because they essentially put a lot of their eye care on pause for the given time frame. And my experience has been in the past few months, I've seen more patients coming back with tractional detachments and advanced disease than ever before. For a while, we were doing a great job taking care of our diabetic patients. I think when they were coming regularly for follow-up and the doors were wide open, I think with COVID, it sort of closed the doors for a period of time and they never really returned.
Yes, we're also seeing a lot of patients, with loss of vision due to neovascular glaucoma, a lot of them, and most of them are, of course, diabetics. That's like the worst, I think, because you cannot even, do anything to return back to normal. So I think we'll go over to the last talk of this session, which has been great so far. And Dr. Rishi will be telling us more about how we can apply the DRCR, studies to clinical practice. And a pleasure to introduce Dr. Rishi, who's also been co-moderating this session, and it's been great having him here. He's a staff surgeon at the Cole Eye Institute Cleveland Clinic and assistant professor of ophthalmology at the Lerner College of Medicine in Ohio. He also currently serves as the medical director of informatics at the Cleveland Clinic. He received his medical degree from Boston University in the prestigious Accelerated Medical Program and completed his residency at the Massachusetts Eye and Infirmary Harvard Combined Program in Boston, MA. He specializes in the treatment of medical and surgical retinal diseases such as diabetic retinopathy and AMD. He has authored more than 60 peer-reviewed publications, books, and book chapters, and serves as the PI of numerous national clinical trials advancing the treatment of retinal disease. He has been honored with several research recognitions, such as the Alpha Omega Alpha Research Award and the ASRS Senior Honor Award. Over to you, Dr. Rishi.
Thank you, Dr. Tran.
Above all that, Rishi is founding president of Retina World Congress, and I think he's doing wonderful, bringing all the societies in the world. So we are with him, and thanks to him for visiting our Dharavi project and also
thank you very much. Yeah, appreciate it very much. My parents be very proud of that introduction, so I appreciate the introduction. So I'm going to talk about the clinical trials from DRCRnet and how they relate to clinical practice. And what you're going to hear is sort of my opinion and take on these things. So please forgive me, and I would love to open this up for a discussion toward the end, because I think it's not necessarily what the studies found, but sort of our interpretation of how they've become into clinical practice today. Here are my financial disclosures for the presentation. So the key points, I'm going to address the numerous topics addressed by the DRCRnet. I'll summarize their finding, and I'll discuss some of their future protocols as they relate to practice. And the DRCRnet, I should say the DRCR Retina Network now, has done so many wonderful studies in the area of diabetes. And now they've expanded beyond the realm of diabetes into obviously AMD, for photography and assessing diabetic retinopathy. They're even looking at conversations you have. They did look for in the studies, in conversations you had with the patient in the office and whether that would decrease the hemoglobin A1C in the patient. So they've done all of these various trials in the past few years, which have really been quite helpful and contributory to the literature. And these are some of the studies that are ongoing now. They're looking at intravitreal gas for vitreomacular traction syndrome. They're going to look at some genetical studies. They're even looking at a photobiomodulation study using light therapy to reduce the effect of DME in some patients. So really exciting and innovative trials they've gone under. But probably the landmark study that people have talked about the most is Protocol Eye. And this was really helpful from us to help better explain sort of the expectations behind DME treatment with our patients. In this study, patients were randomized to either prompt or deferred laser with ranibizumab as treatment in comparison to triamcinolone, as well as just sham laser alone in this population. And what they found essentially was that the number of treatments really decreased over the years as you go along. And this is kind of the first, I think, really interesting finding we saw from any diabetic study regarding DME, that the number of treatments go down as the patient gets treated over time. And so this gives our patients some reassurance. By year 4 and year 5, essentially, you're doing on average on a PRN fashion between 0 and 1 injection in those patients. So really from the patient standpoint and the provider standpoint, this provides a lot of good data for our understanding of how patients get treated in a PRN basis for this practice. One of the other most interesting analyses of this has been this sort of swimming lane approach, that basically within the first 3 months of treating a patient in Protocol Eye with anti-VEGF treatment, that you can actually figure out what their final vision is going to be. And so they presented this post hoc analysis of Protocol Eye to show that after 12 weeks of therapy, essentially you ended up in this single lane for which you never really changed or deviated. And what I can tell you is that this is not necessarily true. And actually, I published 2 studies, both from RISE and RIDE, VIVID and VISTA, where I looked at that limited early response, meaning the lack of visual acuity or OCT at 3 months after initiating therapy. And what we found essentially was in Protocol I, while you had the swimming lanes, in RISE and RIDE, you did not have those lanes at all. And with a more intensive treatment, you actually could get past those lanes. And this is actually the paper we published also in VIVID and VISTA. So essentially that idea of swimming lanes isn't necessarily true, that more intensive therapy will get you past those lanes and allow you to restore the vision in those patients. Probably the more interesting recent study has been around Protocol S, and I think this is very controversial because panretinal laser had been the mainstay of treatment back 30, 40 years now. And I remember as a resident, I was at the Joslin Diabetes Center in Boston, and we used to look at photographs from patients treated with laser 30, 40 years, at that point in time, and they had wonderful outcomes with regards to keeping visual acuity at 20/25 or 20/20, but yet losing all of their peripheral visual field. And this is a great example of a patient here who has proliferative diabetes, 42-year-old female, hemoglobin A1C is 7.9. She's 20/25. She's a mild amount of macular edema here. Definitely not at the threshold where you treat her, but potentially. But yet, with anti-VEGF therapy, we can restore the amount of fluorescein angiography leakage, as well as restore the contour to the retina in this sort of population of patients over time. So the real question becomes is how do we handle patients with proliferative disease with and without DME in the era of anti-VEGF? And that's what Protocol S really looked at, was to look at this 5-year outcome of patients randomized to receiving either panretinal laser or anti-VEGF for the treatment of proliferative disease. Now, I can tell you one of the big drawbacks of this study, because really it didn't answer the question we wanted to answer, was that eyes with or without center-involving DME were eligible. And obviously, if those patients were getting center-involved DME, they were allowed to get anti-VEGF during the course of the study. And the treatment criteria was the same between the 2 groups. Essentially, you're looking at the amount of size or amount of neovascularization that increased in both groups, yet the ranibizumab group got a bunch of loading doses ahead of time. This was actually a 5-year trial, which was good to see the kind of data that we expect to see. But look at the bottom here for just a moment. And just remember, again, this is not a head-to-head study of laser versus anti-VEGF. 22 patients actually had DME at baseline. And so they required anti-VEGF. So really the PRP group, a lot of them were getting anti-VEGF. And the ranibizumab group, obviously was getting the anti-VEGF for DME alongside the treatment of proliferative disease. And here's the final outcome of the study, which showed again that there was an improvement in patients with baseline DME, obviously in anti-VEGF, but without baseline DME, the visual results were kind of equivocal. But again, I will tell you that the PRP group here also received some anti-VEGF as they went along, because even if you didn't have baseline DME and you developed DME as this trial continued, you were eligible to get anti-VEGF as that went on, and that was not an uncommon situation. So just the 2-year outcomes showed a superiority of visual acuity with regards to ranibizumab or anti-VEGF treatment, less peripheral visual field loss, 3-fold less vitrectomies, and it's cost effective when DME was present. But again, PRP was favored because it had fewer visits, fewer injections, and was cost effective when DME was not present. They went out to 5 years. And again, you can see that very good trend that we saw amongst many studies, where we saw a decrease in anti-VEGFs as the trial went on, which was very, very reassuring. And again, you see that the number of treatments outside this condition are very low. The end of the trial essentially showed an equivalence as far as the visual acuity. But one thing people forget about this study was that they looked at this graph and this slide, and they say, well, the patients in the anti-VEGF arm still lost vision, or lost visual field, I should say. And actually, this was statistically different from each other. The p-value was less than 0.05 in this group. So yes, there is progressive ischemia in our diabetic patients, but it is still better peripheral visual field wise than those patients who were receiving PRP as a result of that. And again, the 2-step retinopathy improvements in anti-VEGF were not seen in the PRP group because of the fact that they did get that. Very equivalent numbers of side effects seen here. Again, the vitrectomy rates were lower, yet the vitreous hemorrhage rates were really quite significant. So over 5 years, again, we saw a relatively nice improvement in patients who had DME at baseline. And again, PRP was favored for fewer injections and fewer visits. But how do we do it in real practice? This is really a blended approach. It's a blended approach of if DME is present, we treat with anti-VEGF clearly. But even if DME is not present, a lot of us treat with anti-VEGF in between our PRP treatments in clinical practice today, and that's been reflected in a lot of the ASRS data as well. I'll just quickly walk you through Protocol T, and I think it's important to show you some findings from this study. Protocol T compared patients with aflibercept, bevacizumab, and ranibizumab on a head-to-head basis. But what they did essentially was found that aflibercept was superior in many fashions along the primary endpoint, showing you the improvement in visual acuity, but also with secondary endpoints as well. Obviously, if vision is 20/40 or better, that fell off. And so all the drugs were essentially equivalent in practice. And again, looking at that 2-year outcome, you saw that same improvement. And here you can see, again, as vision got worse, you see that improvement in visual acuity as time went on, especially with the aflibercept over controls. But all 3 anti-VEGFs were considered effective for vision 20/40 or better. That was sort of the takeaway. But here is a graph I can show you, and I'll show you this graph. It's kind of busy, but in this lower left corner here, look at this breakout of patients with 400 microns or thicker retinas and comparisons between Avastin, Lucentis, and Eylea. Even in good vision states, Avastin performed much poorer, almost 5 letters poorer than Lucentis and Eylea in this group. So for those patients who have that, increased retinal thickness, we would use obviously either Lucentis or Eylea in those patients for the treatment of DME, even despite the fact their vision might be 20/40 or better. And let me just finish up with this study, which is obviously the Protocol V Good Vision study, which looked at the management of patients with good visual acuity. Whether you observe them laser, then this patient has 20/20 visual acuity. What should I do in this case? And that's what Protocol V really looked at. It looked at the change in visual acuity in those who got prompt anti-VEGF or prompt laser and deferred anti-VEGF or observation only, and found essentially that they had very equivalent changes in retinal thickness. So the conclusion was that you could wait on these patients until they got worse and then treat them if that's the case. Well, the problem here is the following. You have a limited timeline of up to 2 years. You have healthy patients, 7.1 A1C was most of the patients in the study, and you had to have good patients and motivated patients to be within a clinical study. This is not real world. And so for what we found essentially is that there's a definite risk factor for progression in patients with the eyes in Protocol V. For example, if your fellow eye was receiving anti-VEGF, you had a 2.5-fold greater likelihood of progressing. If you have eyes with severity score greater than 47 to moderate severe non-proliferative disease, or if you have baseline CST greater than 300 microns, you're a 2-fold greater to progress. And so that's where I think this is a very important study to look at and to evaluate. So just to conclude my talk today, I think the Retina Network has done fantastic studies with regards to diabetic patients. They've expanded the scope now to encompass all retinal diseases. It's a highly experienced infrastructure. They're looking at many protocols. Even you all today watching can suggest protocols to the DRCRnet, and they will work with protocols in the United States. And they have many ongoing studies looking for more innovative trials as we go forward. And again, this is looking at many different retinal conditions. And I think that we owe a debt of gratitude to what the DRCRnet provided, albeit I think that there's some real world implications to the studies and what they're doing. Thank you very much.
Thank you, Dr. Rishi, for summarizing that. I know it's a tough job with so many studies and so many findings, and bringing out the clinical relevance of each one of those studies, I think was fantastic. So if the rest of the panel have any questions to Dr. Rishi or each other, please, you're most welcome, because we have a couple of minutes more for discussion.
Rishi, that was an excellent talk, and I just want to say that this DRCRnet network really answered a lot of our burning questions and issues regarding diabetic retinopathy, including for vitreous surgery and for diabetic macular edema.
And I think about Protocol S, you put it so properly that it has a certain amount of, clarity needs to be, understood because the visual fields deteriorate. So, of course, we follow the blended approach also, and I totally agree with you on that. So it's a very healthy ongoing network of trials, which will really help the world overall.
Yeah, I think it's always hard to equate these trials to real world clinical practice, and they've done the best they could, but there's still some
Yes.
gaps there and we need to understand them.
Right.
Soon, because I'm sure he's busy in another session. We have Mona.
Dr. Kim, please. You wanted to ask something, Dr. Kim?
Thank you for this nice summary of the DRCF clinical trial. In practice, like in the US, there's most of the either PRP or they get injections.
So do most patients get PRP or injections? Yeah, so the ASRS BAT survey has shown thus far that most patients are still getting PRP. It's about 25% of retina specialists are delivering anti-VEGF as a mode of therapy. I will say though, Dr. Kim, in real practice, it's a blended approach, meaning that if you did a PRP today, or you're planning on a PRP, you might schedule the patient within 2 weeks for the PRP in your clinic because you don't have time. But in the meantime, you'll give them an anti-VEGF, and then you'll wait for 2 weeks or 3 weeks, whenever you get a chance to schedule them. And then you might do an anti-VEGF if you don't get a response you expect to see with the PRP, even before repeating the PRP again. So I think a lot of us do a very blended approach now. And I think Protocol S, the big finding for me in Protocol S was it wasn't a progression of tractional retinal detachments despite getting anti-VEGF. That was a big, I think, safety signal for all of us to see that there wasn't a worsening of that condition.
The issue here is, keeping the patient compliant for long-term care, especially in a country like India, is really a big challenge.
Yeah. Yeah, and I know
cost as well.
Cost as
is
well.
a big thing for us.
It's the same here. It really isn't different. Compliance is very poor. They say that in an anti-VEGF DME population, they miss appointments 25% of the time. And that's a pretty large amount. And so that's a concerning thing for us.
Yeah, I think COVID showed the relative benefits of, say, PRP in a totally non-compliant population. So if we knew that we couldn't see our patients for 6 months, which has happened often in COVID, then PRP would be better. But, I tend to use much less PRP in general and use anti-VEGF injections. And some of my patients, I think, suffered for that a little bit because of the delays due to COVID. So that's changes a little bit our way of thinking, I think, about this as we go forward.
Rishi, do you load them at all? You load them with anti-VEGF? Because I also do a blended approach.
Yeah, I don't load them. I tend to give them an anti-VEGF and then I decide based upon, I think that the idea of high-risk characteristics has kind of gone out the window. We used to look at high-risk characteristics and then decide if we're going to laser. I think with wide field imaging, as you've shown, it's opened our world up to looking at neovascularization better than ever before. And so, we tend to treat earlier. So the question becomes is, do you really need, a loading period for the anti-VEGF? There's not been a good study to show that other than Protocol S that was done that way. I don't tend to do that in my own practice. If I'm doing that for example, in a strictly anti-VEGF treatment, I'll do serial photographs to follow the patient over time, and I'll give them injections, but then I'll start to spread them out. And some studies recently have actually shown, it was Protocol AB actually that did this recently with the aflibercept, showed that you can actually go out pretty much by every quarter by the first year in most of the patients who treat with EYLEA.
Do you have any endpoint of treatment in these patients?
That's $1 million question. I wish. I think obviously with PRP, that when there's when you don't have any retina left over, you're done treating, right? But then with anti-VEGF, it can continue forever, and that's a real concern. So.
Quite a few patients, I can say, come back after a year post PRP, but you can never do that with
yeah,
post-injection.
yeah, wonderful.
Great. If no other questions, I think we can go ahead and conclude. I must express my gratitude for all of you all getting up really early in your day on a Sunday. At least for us, it's literally the end of the day. And being part of this session, a lot of insights into the management, both medical and surgical, and particularly wide field OCT. I think imaging we're quite used to, but OCT was amazing as well. Thanks to all of you and our host faculty as well. We've covered screening, we've covered a whole gamut of it. I invite Dr. Rishi to give the concluding remarks, please.
Yeah, thank you for everyone joining this program. You know, obviously the American Society of Retina Specialists is pleased to be here at this conclave today, and really appreciate your hospitality and hope to see you all in the near future in person. So good luck to everyone.
Rishi, they are waiting for us in the other session.
Yes.
Yeah.
See you soon.
Thank
Bye-bye.
you,
Everybody take care and stay
Thank you,
safe.
Carl.
Bye.
Thank you, Nathan. Thank you, Kim, and thank you, Atul.
Yeah, thank you.
Thank you all.
Very
डॉक्यूमेंट वाले एक दूसरे को इंक्रीज कर रहे हैं